Welcome to the deep dive. Today, we're jumping straight into the world of pharmacology.
You know that feeling, right? That sudden catch in your chest, or maybe just feeling really out of breath doing simple things.
Yeah, it's definitely unsettling.
It really makes you stop and think, oh, what's my body trying to tell me?
Exactly.
So today we're doing a deep dive into angina pectoris, that chest discomfort feeling, and crucially, the medications used to manage it. Think of it as getting under the hood, understanding those signals from the heart, and the clever ways we've found to restore balance.
And our discussion, it's really grounded in the pharmacology, looking at how these antianginal drugs actually work.
Right. Gives us a solid base.
It does. It's a really robust way to approach a condition that affects so many people.
Absolutely. And our mission here is basically to pull out the key stuff about angina and the treatments, cut through some of that medical speak, and just focus on, what's really important to grasp.
That's good.
Okay, so let's jump in. What exactly is angina pectoris at its core?
Well, in simple terms, angina pectoris is chest pain. And it happens when the heart muscle itself isn't getting enough oxygen.
Okay.
We call that myocardial ischemia. It's fundamentally an imbalance, like a seesaw. The heart muscle needs more oxygen than it's actually getting.
So the heart's basically being starved of oxygen. What typically causes that supply to drop off?
Well, several things can tip that balance the wrong way. The most common one is atherosclerosis.
Okay, atherosclerosis.
Yeah, that's where plaque builds up inside the arteries, narrows the passageway, restricts the blood flow. Think of like a pipe getting clogged up over time.
Right, I can picture that.
Then there's also vasospasm. That's a sudden sort of clenching or tightening of the heart's arteries.
Ah, like a kink in the pipe.
Exactly. Just temporarily cuts down the blood flow. And then, of course, you can have a thrombus, which is a blood clot.
And that would be like a complete blockage.
Pretty much, yeah. A major blockage in the artery.
Okay, that covers the supply side pretty clearly. But what about the other side of the seesaw? When the heart demands more oxygen, what makes it work harder?
Good question. The heart's oxygen needs to shoot up when it has to pump harder or faster.
Like exercise.
Exactly, like during exercise or even under stress. Also, increased contractility, that means the heart muscle is squeezing with more force. That burns more oxygen.
Okay.
And finally, there's increased wall tension. That's basically the strain on the heart muscle itself as it pumps. More strain, more oxygen needed.
Wow, so it's a really a delicate balance then, and when that balance gets thrown off...
That's when the Bain signal fires.
Right.
Exactly.
Okay.
The sequence is pretty direct. Myocardial ischemia, that oxygen shortage, leads to angina pain. It's the body's way of sounding the alarm, basically.
No, I know angina isn't just one single thing. There are different types, aren't there? Why is that distinction important?
Yeah, knowing the type is really key. It tells us a lot about what might be going on underneath and, frankly, how urgent things are. So you have stable angina. This type, it generally follows a predictable pattern.
Predictable how?
It's usually triggered by physical exertion, like, walking up a hill or climbing stairs, and it gets better when you rest.
Ah, okay. So it suggests something more chronic, maybe.
Often, yes. A more manageable situation, typically.
Got it. So stable angina is somewhat predictable. What about the others?
Well, then there's unstable angina, and that one's definitely more concerning.
Why is that?
Because it can happen even when someone's just sitting still, at rest. The big red flag that the underlying problem is getting worse.
So, like a warning sign for a heart attack.
A significant one, yes.
Yeah.
It really bumps up the risk. And then there's a third type, variant angina, or Prinzmetal angina.
Or Prinzmetal, okay.
Yeah, and this one's interesting because it's usually caused by a spasm.
A spasm, not a blockage.
Right, a sudden spasm in the coronary arteries, rather than a fixed narrowing from plaque. So it's a different mechanism entirely. The artery just clamps down temporarily.
Huh. But the result is the same, reduced oxygen.
Exactly. Same result, different immediate cause. And it's interesting, because calcium channel blockers are often really effective for variant angina.
Oh, why is that?
Because they directly relax those blood vessel walls, which can counteract the spasm itself.
Okay, that makes sense. So, considering these different causes and types, what are the main goals when we talk about treating angina? What are we trying to achieve?
Broadly speaking, there are two main goals in treatment strategies.
Okay.
First, boost the oxygen supply getting to the heart muscle. And second, decrease the heart muscle's demand for oxygen. Get that seesaw back in balance.
Boost supply, decrease demand. Got it.
So how do we actually increase the supply?
Well, we have a couple of main approaches. One is revascularization.
Revascularization.
Yeah, procedures to restore blood flow. Like PCI, that stands for percutaneous coronary intervention.
Okay, what's that involve?
Think of it like minimally invasive plumbing for the heart arteries. Often involves inflating a tiny balloon to open the artery and maybe placing a little mesh tube called a stent to keep it open. Angioplasty and stents.
Exactly. Or there's CAVG, coronary artery bypass grafting.
That sounds more major.
It is. It's surgery where they use healthy blood vessels from elsewhere in your body to create detours, basically, around the blocked sections of the heart arteries.
Right. And besides those procedures,
We also use medications, vasodilators.
meaning they widen blood vessels.
Precisely. Drugs like nitrates and calcium channel blockers work to relax and widen those vessels, letting more blood and oxygen through to the heart muscle.
Okay. And then on the other side of the equation, how do we decrease the heart's need for oxygen? Lessen the demand.
Right. Several drug classes help here. Nitrates actually do double duty.
Oh, how so?
Well, besides widening vessels, they also reduce something called preload.
Preload.
Yeah, think of it as the amount of stretch on the heart muscle just before it contracts. By relaxing the veins, nitrates reduce the amount of blood returning to the heart, so there's less stretch, less preload.
Meaning the heart doesn't have to work quite as hard to pump.
It's exactly. Less work, less oxygen demand. Calcium channel blockers also help by reducing afterload.
Afterload. Okay, what's that?
Afterload is the resistance the heart has to push against when it ejects blood out into the arteries. CCBs relax the arteries, lowering that resistance.
So again, less work for the heart.
Right. And then we have beta blockers. These are really key players.
Beta blockers, what's their main job?
Their main job is to slow the heart rate down and reduce the force of the heart's contractions.
Okay.
Both of those actions directly lower how much oxygen the heart muscle needs to function. They work on specific receptors in the heart, beta-1 receptors mostly, which are involved in that fight-or-flight response that can stress the heart.
Gotcha. Okay, let's dig into these main drug classes a bit more. Nitrates first. How exactly do they work? You said they release nitric oxide.
Yeah, that's the core mechanism. Nitrates get converted in the body, releasing nitric oxide, or NO.
And what does the NO do?
This NO then sets off a chain reaction, basically increasing levels of another molecule called cyclic GMP, or cGMP.
Okay, CGM.
And it's this increase in cGMP that causes the smooth muscle cells in the blood vessel walls to relax.
Leading to that widening, the vasodilation.
Exactly. And it affects both veins, which reduces the preload, like we said, and arteries, which reduces the afterload. So it's a really neat double action.
Hitting both preload and afterload. Clever. What are some, common nitrates people might actually use?
Well, for really quick relief, like when angina pain actually hits, the standard is often sublingual nitroglycerin.
Under the tongue, right?
Yeah.
Tablets or spray.
Exactly. They get absorbed fast that way. For more long-term prevention, what we call prophylaxis, doctors might prescribe something like oral isosorbide monotrate.
Taken regularly.
Usually, yeah. Although there's something to watch out for there, tolerance.
Tolerance, like the drug stops working as well.
Potentially, yes. With continuous round-the-clock use, the body can become less responsive to nitrates. That's why doctors often plan for a nitrate-free period each day, maybe overnight.
To give the body a break and keep the drug effective.
Precisely. Helps prevent that tolerance from developing.
Okay. What about side effects with nitrates? Are they common?
Yeah, some are pretty common. Headache is a big one.
Makes sense if blood vessels in the head are widening too.
Exactly. And hypotension, low blood pressure can also happen. Again, logical given the vasodilation. And then, as we mentioned, that potential for tolerance.
Right. Okay, let's switch over to beta blockers. We know they slow the heart and reduce contraction force. How do they achieve that on a cellular level?
They work by blocking specific receptors on heart cells, primarily beta-1 receptors.
The docking stations you mentioned.
Yeah, you can do them like that. These receptors normally bind to hormones like adrenaline, which tells the heart to speed up and beat harder.
Fight or flight.
Right. Beta blockers basically get in there and block those docking stations. So adrenaline can't latch on and deliver its message as effectively.
So the heart stays calmer.
Essentially, yes.
Yeah.
The result is a lower heart rate and less forceful contractions. And that directly cuts down the heart's oxygen requirements.
What are some common beta blockers people might have heard of?
Drugs like propranolol and metoprolol are very common examples.
And they're used just for stable angina.
Primarily for stable angina management, yes, but they're also really important standard therapy after someone's had a heart attack. Helps protect the heart long term.
Are there times when beta blockers are not a good idea? Contraindications?
Yes, definitely. There are some important ones. For instance, in people with asthma.
Why asthma?
Because some beta blockers, especially older ones like propranolol that aren't selective just for the heart's beta-1 receptors, can also block beta-2 receptors in the lungs.
And that causes?
That can cause the airways to constrict bronchospasm, which is obviously dangerous for someone with asthma.
Okay, crucial point. Any others?
Yes. Also invariant angina, the spasm type. Using a beta blocker alone can sometimes backfire.
How so?
Because if you block the beta receptors, you can leave the alpha receptors in the blood vessels sort of unopposed. And alpha receptor stimulation causes constriction.
So in a spasm situation, it could actually make the constriction worse?
Potentially, yes. It's a bit complex, but it's a key reason why they're generally avoided or used very cautiously in variant angina.
Wow. Okay. That's a really important safety info. Now let's move to the third big group. Calcium channel blockers, CCBs. You mentioned there are different types.
Yes, we broadly split them into two groups. Dihydropyridines, let's just call them DHPs, and non-dihydropyridines or non-DHPs.
Okay. DHPs and non-DHPs. What's the main difference?
The DHPs, like nifepine or amlodipine, their main effect is vasodilation. They're really good at relaxing and widening blood vessels.
These are mostly focused on the vessels.
Primarily, yes. The non-DHPs, like verapamil and diltiazem, they also cause vasodilation, but they have a significant effect on the heart itself, too.
How so?
They directly slow down the heart rate, similar in effect to beta blockers in that regard, and can also reduce contractility somewhat.
So DHPs are mainly vasodilators. Non-DHPs are vasodilators, plus they slow the heart rate.
That's a good way to summarize it, yeah.
And how do they work? They block calcium channels, obviously, but what does that do?
Right. They block specific channels called L-type calcium channels. These channels are found in the smooth muscle cells of blood vessels and also in heart muscle cells.
Okay.
Calcium entering through these channels is what triggers muscle contraction. So by blocking them in blood vessels, you get less contraction, which means relaxation and vasodilation.
And in the heart?
In the heart, blocking calcium entry reduces the force of contraction, and in the case of non-DHPs, it also slows the electrical signal that sets the heart rate.
So overall, less work for the heart and better oxygen supply through wider arteries.
Exactly. It tackles both sides of the supply-demand equation.
Do these two types, DHPs and non-DHPs, have different side effect profiles we should know about?
Yes, there are some key differences. For example, the DHPs, like nifedipine, because they're such potent vasodilators, can sometimes cause a drop in blood pressure that triggers a reflex increase in heart rate.
Oh, reflex tachycardia, the body trying to compensate.
Exactly. Whereas the non-DHPs, like verapamil, since they actively slow the heart rate, the concern there might be the opposite bradycardia or an excessively slow heart rate.
Okay.
And verapamil specifically is also kind of known for sometimes causing constipation.
Huh, interesting. So knowing these nuances helps doctors choose the right one.
Definitely. Tailoring the choice to the patient's specific situation and other conditions is key.
So we've got these three main pillars: nitrates, beta blockers, CCBs. Do doctors ever use them together? Combine therapies?
Oh, absolutely. Combination therapy is very common and often more effective.
What's the thinking behind combining them?
Well, take nitrates and beta blockers, for example. Nitrates are great at reducing preload, right?
Right.
But they can sometimes cause that reflex tachycardia we just mentioned. Adding a beta blocker counteracts that by keeping the heart rate down, so they work well together.
Complementary effects. What about CCBs and nitrates?
That combination gives you enhanced vasodilation. Both drug classes widen blood vessels, so using them together can really boost blood flow, which might be needed in more severe angina.
Makes sense. Are there any combinations that are a definite no-go, things to absolutely avoid?
Yes. One really critical one to remember is combining beta blockers with verapamil, one of those non-DHP calcium channel blockers.
Why is that one dangerous?
Because both drugs significantly slow the heart rate and also slow down the electrical conduction within the heart.
So putting them together.
Exactly. Putting them together creates a really high risk of causing severe bradycardia or even heart block. Where the electrical signals get dangerously disrupted, it's generally avoided.
Okay, that is a super important safety point. Vital takeaway. Now, shifting slightly, what about in the middle of a heart attack, an acute MI? How does angina management relate to that emergency situation?
Well, in an acute MI, the immediate focus is often on things like chewing an aspirin quickly to stop clots, maybe morphine for the intense pain.
Right, emergency measures.
Yes. But then looking at the medications that overlap with ongoing angina management, beta blockers are usually started early after an MI, if appropriate for the patient.
To protect the heart.
Yes, to reduce its workload and oxygen demand during a vulnerable time. And statins, for cholesterol lowering, are also standard post-MI care, which also helps stabilize plaques long-term.
You mentioned statins, and I think you mentioned a mnemonic earlier, STAIR, for some other drugs used in angina.
Ah, yes, STAIR. It's just a handy way to remember some other classes that can be part of the picture.
Okay, break it down for us.
Sure. S is for statins, primarily for lowering cholesterol, stabilizing those artery plaques. T is for trimetazidine, which we'll touch on. A is for antiplatelets.
Like aspirin.
Exactly like aspirin or clopidogrel, to prevent blood clots. I is for ivabradine.
Ivabradine, what does that do?
It specifically targets the heart's natural pacemaker, the SA node, to slow the heart rate down, but through a different mechanism than beta blockers.
Okay. And
R is for ranolazine, another antianginal drug with a different mechanism, thought to affect sodium and calcium movement in heart cells.
And you mentioned trimetazidine briefly.
Yes, trimetazidine is thought to help the heart muscle use oxygen more efficiently, kind of optimizing its energy metabolism, though the exact details are still studied.
Okay, so STAIR covers statins, trimetazidine, antiplatelets, ivabradine, ranolazine. Quite a few options beyond the main three.
Indeed. And there was one more we touched on earlier, Nitrates.
Right, Nitrates. What was unique about that one?
It has that dual action. It opens potassium channels.
And that causes?
That leads to both arterial vasodilation, widening arteries, improving supply, and venous vasodilation, widening veins, reducing preload. So it hits both arteries and veins.
Interesting. A sort of combined effect in one drug?
Kind of, yes.
Okay, so pulling this all together as we start to wrap up, if you had to boil it down, what are the absolute core things to remember about these main antianginal drugs?
Well, I'd say think of nitrates as your go-to for quick relief, mainly working through vasodilation.
Okay, nitrates for fast relief.
Beta blockers are primarily about decreasing the heart's oxygen demand, slowing it down, reducing the force of contraction.
It's work for the heart.
Right. And calcium channel blockers, their main game is vasodilation to increase oxygen supply, although the non-DHPs also chip in by slowing the heart rate.
Got it. Nitrates for relief, beta blockers for demand, CCBs for supply.
That's a pretty good simplification, yeah.
And fundamentally, it all comes back to that balance, doesn't it? Oxygen supply versus oxygen demand for the heart muscle.
Absolutely. That's the central concept. Every treatment strategy we've discussed, whether it's drugs or procedures, is ultimately trying to nudge that seesaw back into balance.
Right.
And remembering the different types of angina, stable, unstable variant, helps frame why certain treatments are chosen and highlights the urgency, especially with unstable angina. That's a real warning sign.
Definitely. So finishing up this deep dive, it's really clear that managing angina is complex. It's about understanding this intricate dialogue between the heart and the body, and how these medications cleverly intervene to restore that harmony.
That's a great way to put it.
Yeah.
And, it's crucial to remember this isn't just about pills. Lifestyle factors, ongoing medical care, they're absolutely vital pieces of the puzzle.
For sure.
So if you or someone you know is having symptoms like this, the most important thing is always to talk to a doctor. Get personalized advice.
Absolutely critical. And it leaves you wondering, doesn't it? Given how interconnected everything is, supply, demand, vessel health, what other things, maybe things that seem unrelated in our health, could actually significantly impact angina?
That's a fascinating question.
Yeah.
And looking forward, how might research give us even more targeted, more personalized ways to treat these different kinds of angina we've talked about today?
Definitely some food for thought.